Good morning, everyone. A very warm welcome to today's JMitra Scientific Webinar. We're truly delighted to have all of you join us for this important session on modern approaches in diagnosis of cancer markers and the significance of automation in the clinical laboratory. As diagnostic technologies evolve rapidly, it is essential we stay informed about the latest innovations that are shaping the future of clinical diagnostics, especially in oncology and lab automation. Today's session aims to equip us with deeper insights that can enhance both clinical outcomes and operational efficiency. It is our privilege to have with us Dr.Subhosmito Chakraborty, a distinguished expert in the field, currently serving as senior consultant in HOD biochemistry at the Tata Medical Center in Kolkata. His rich experience and work at one of the country's leading institutions make him the ideal person to guide us through this topic. Without further delay, I now hand over the session to Dr. Chakraborty. Thank you, sir, for joining us today. The forum is yours.
Thank you, Mr. Mahajan. A very good morning to everybody. And thanks for tuning into this webinar on a Saturday morning. And it has been organized by JMitra. Thanks to them as well. So I'll be speaking to you about the modern approaches in diagnosis of cancer markers and significance of automation in clinical laboratory. So this will be a brief overview of the entire thing, because if you look at the discipline immunology, it's very vast, and many things will be out of scope of diagnosis and discussion in the short period of time. Okay, so before we discuss the technologies, these are the basic foundations which we will have to discuss, because without them, the discussion remains incomplete. So how do you define a tumor marker, and what's a tumor marker? It's a substance produced by the tumor or the host in response to the tumor, which is used to differentiate a tumor from its normal tissue, or to detect the presence of a tumor based on measurements in blood and secretions. Now, where would you find these tumor markers? They are usually found in cells, tissues, and obviously body fluids. That means blood, and they are detected by chemical, immunologic, molecular, or other biological methods. Now, the tumor marker secretion depends on several things. For example, it depends on how well differentiated a tumor is. A poorly differentiated tumor may actually secrete more amount of this marker. Anaplastic. Similarly, anaplastic and de-differentiated tumor markers may secrete more amounts of the marker. And how much as the genetic counterpart do you have the re-expression of fetal counterparts of the molecules? Actually, when you go back and see the biology of tumor markers, what you find is that they are more like the old molecules which were being produced by the fetus during the development. That's what makes a tumor marker interesting and different in the body. Now, everything has an ideal. Tumor markers are not an exception. Tumor markers should be specific for a tumor. So when you are thinking of a tumor marker, so it should be specific for that. Sensitive to a small tumor. Small means the volume. Even if the volume is low, even if it is not detectable by an image, the tumor marker should be detectable or be present. It is present in normal tissue as well, but there is a cutoff above which the tumor marker increases. So it is present in a variety of tumors. Non-tumorigenic conditions, it may increase, but not as high as what it would be in tumors. And the current use of tumor markers is in monitoring progress or follow-up after therapy. It may be medical oncology based therapy, radiotherapy, or surgical intervention or surgical therapy. How many types of chemical molecules can act as tumor markers? Well, there are a plethora of them. And as you can see, they can be enzymes, they can be hormones, oncofetal antigens, carbohydrate markers, blood group antigens, proteins, receptors, and genes. Obviously, I am not going to give you a list of them. You take up any good textbook or a publication, and you will be able to find what each of them are. But amongst all of these, the first one was the earliest ones to be discovered, and at present, very few enzymes are actually in vogue for detection of tumor, but they can act as supplementary evidence. Let's say, for example, LDH. If it's a cancer institute and you are measuring LDH, so it's a very surrogate to the presence of AML or some blast crisis, increased white blood cell counts, and so on. Because even before the other histopathology and anything comes up, so people know that this is pointing towards a tumor. Obviously, if you look at what cancer is, you have to take into account the biology of the thing. Cancer is a growth of autonomous tissue due to a loss of tumor suppressor gene. Activation or altered expression of oncogenes are also responsible. Molecular damage is often linked directly to DNA or increase in cell proliferation by hormones. Symptoms. Usually, when the person becomes symptomatic, the tumor is too large. And there are a few things which are known to cause tumor, and they can be like chemical, radiation, and many such things. We are basically in the fourth to fifth era. We are actually transitioning into the fifth era. It all began in 1874 when Bence-Jones proteins were discovered, and Bence-Jones proteins in urine meant that there were something abnormal related to the bone marrow, and it was producing fracture of bones. From the 20s to 60s came the enzymes, hormones, proteins, and beginning of chromosomal studies. Between 64 to 75, that decade saw an increase in the measurement of or the use of carcinoembryonic antigen and alpha fetoprotein. 1975 to current, you have a growing body or an evidence of tumor markers like monoclonal antibodies for various tumor markers, various genes in molecular diagnostics, so on. Even some immunochemical stains in histopathology, for example, S100, NSE, they are becoming available in the market. The clinical applications are important. You have to note because often what people do is use tumor markers as the first line of evidence for the presence of tumor. Now, that is the least possible way you can use a tumor marker. A tumor marker is always supportive in diagnosis. It's not an indication of tumor at all, whatever be its value. So, current practice in India, often we see that people, at least in tier 2 and tier 3 cities, they tie the value of presence of a marker to the presence of a tumor, which is not true. The markers must be combined with other investigation modalities, chiefly histopathology and imaging, to gain a proper clinical insight. Other than that, you cannot say whether a tumor is present or not. On their own, they may be very important in follow-up, because think about it. You cannot, if there is a colon cancer, a patient of colon cancer, and you cannot take repeated biopsies from the margin. It's just not possible. So what is possible is basically to take blood or a body fluid or some non-invasive method and check the value of the same. So that's what I have written, that it is of limited usefulness in screening. So one should not go with the view that one can screen the population using a tumor marker. That is never to be done. So it is limited in screening, diagnosing, prognosing, and staging. Sometimes some tumor markers are used in prognosing or even detection of recurrence and remission. They are either the evidence, if you use the evidence-based pyramid of the current modern medicine, they're either limited or they are controversial. For example, I can tell you that there was a large study on the use of CA-125. Just like self-breast examination is an example on which people can detect early breast cancers, it's said. So CA-125 was added to that study, but later on, there were several fallacies which were found out, and it was ruled in that you cannot use CA-125 as a marker for screening in your population. General uses of tumor markers can be done if incidence is high. If incidence in the population, for example, a group is known for certain practices which can induce tumor, then you can use, for example, even though it's an analogy, after 40, colonoscopy is recommended for the health of the colon. And in US, people do it. So if the incidence is high for a certain population, then you can use that marker for screening. Marker concentration for individual patients for prognosing, that is of course done. Detecting cancer, recurrence and remission in specified populations. Now, which population? Population which is coming to you for follow-up. So if you are a clinician, then you know whom to get into this business. If you are a laboratorian or somebody who is a laboratory scientist or a technologist, then you know that depending on the hospital that you are working in, the follow-up population are the ones in whom at least there are 3 data points which concurrently show increase, even if it is within the reference interval. There may be a requirement for investigating the patient further and monitoring the effectiveness of therapy, of course, whether you are giving radiation, chemoradiation, adjuvant, neochemotherapy, or something like that. They are a surrogate in monitoring the effectiveness of therapy. Clinical utility. One major issue is the reference intervals. We do not have Indian reference intervals of tumor markers, but it seems that with the adopted reference intervals, we do a sort of a good job, but we should be having our own reference intervals, particularly as new companies are coming up. They are importing kits or either producing it in the Indian market. So we with a particular antigen epitope. So it's better that we have our own reference intervals. predictive value model. Now, predictive value model means there are certain things, for example, if beta 2 microglobulin increases 50%, by 50%, so there is a chance of recurrence. During surgery, intraoperative, if there is a more than 50% drop in the intact PTH molecule, because here you are not using PTH as a hormone, you are using it as a tumor marker. So there is a parathyroid adenoma, dissection is going on, and serial samples are being sent to you at any point of time. Say between the first sample and the fourth sample, there is a decrease of more than 50%. It is assumed that a good surgical resection has taken place, and we often do this. So that's a predictive value model of a tumor marker, particularly with the new tumor markers which are coming up. We should be seeing certain predictive value of that marker. Distribution of markers. Distribution of markers. Markers are shared. For example, CEA, CA19-9. They are all shared by the gastrointestinal tract. So you cannot pinpoint. Even for example, AFP, if you add AFP, 19-9, CEA, they can come from any part of gastrointestinal tract, though traditionally we tend to associate CEA with colon, CA19-9 with pancreas, but it's rarely the case. Some sort of clinical guideline and protocol should be followed by the institute for use of tumor markers. They should not be used rampantly and as a first line in diagnosis. You can use it for the first time, but not first time for diagnosis. You cannot tell the patient that, okay, you have high tumor marker, so there is a high possibility that you do have a tumor. The most common tumor markers, I have listed it out. So you have one enzyme there at the bottom, but newer markers are coming up. I already told you HE4, S100, NAC, many others. The enzymes are no longer much in use, but they are used to support, for example, in tumors where you are giving rasburicase for tumor lysis syndrome. G6PDH becomes an enzyme which you need to monitor either semi-quantitatively, quantitatively or qualitatively. Prostatic acid phosphatase is not used much nowadays. The thing is, if there is a cellular damage which leads to enzyme leakage in blood, inflammation can also be responsible for such leakage. So that is why it has fallen out of favor, because cancer patients have a tumor burden and they also have a sort of inflammation going on. So there is a cytokine storm which is actually going on within the tumor. Enzymes often rise very late, and by the time they rise, the tumor has often metastasized. Isoenzymes by electrophoresis or chromatography can aid in separation of the tumor. For example, somebody who has come in your clinic has got a very raised alkaline phosphatase. So you rule out they're not, there is no liver disease. Then you look at the isoenzymes. Maybe it's a high deformed mole which is secreting the enzyme. So isoenzymes can add to some tissue distinction. An ideal tumor marker has got certain properties, should be produced by the tumor itself, it's rarely the case, should not be present in healthy tissue. It's not a thing, because, for example, take PTH. It's used as a tumor marker. How can you say that it's not present in healthy tissues? Plasma level of a tumor marker should be at a minimum level in healthy subjects and in benign conditions. So what is done in benign conditions, we do have the tumor markers going up to a certain level. There might be a cutoff in evidence-based medicine, a decision limit, and in cancers, they shoot up. A tumor marker should be specific for a tissue. Plasma levels of the tumor marker should be in proportion of both size of tumor and activity of the tumor. Well, this is somewhat controversial, but it does relate to the volume and activity of the tumor. Half-life of a tumor marker should not be very long, otherwise it interferes. It interferes with the monitoring and follow-up of the case. Tumor markers should be present in plasma at a small detectable level, even though tumor size is very small. That means what they're trying to say is even before the appearance of the tumor, either clinically or even in imaging, if there is a suspicion, you should be able to detect the tumor marker. So you have looked at these 7 conditions, which are the ideal properties of tumor markers, but most of the tumor markers satisfy 1 or 2 conditions, but not all, and this is common knowledge. These are some of the things that I just given, and I've already gone through, so I'm not repeating it. Again, coming back and re-stressing on the fact, never use in screening until and unless a population is known to be susceptible to a certain kind of tumor. Differential diagnosis of symptomatic patients, clinical staging of cancer in some areas, estimating tumor volume for some cases as a prognostic indicator for disease progression, yes, and evaluation of the success of treatment or therapy, yes, of course. The last 2 points are very important. So we were talking about technologies. Earlier, what used to happen is we used to have a sheep farm or a mouse farm or animal farm where we could inject and take out the antibodies, purify the antibodies or the antigens, and use them as to detect tumor markers. Now what has happened is they are all commercialized. Some of them are synthetically produced. Some of the kits are the products of genetic engineering. It has mass production. They are not produced by horses or some other animals, and purification is much, much easier because the cell lines are producing that particular antigen or antibody what is desired. So technologies are becoming more and more, they are patented. How actually the things are taking place are not very clear to us. So I will just touch upon a few, but I cannot be describing because these things are not being common knowledge, and it's extending beyond what we can capture just by doing it manually. For example, if you had to do chemiluminescence by hand, imagine the type of arrangements that you would need to have, and each institute might be doing it very differently. And the other thing that people are stressing on is the kind of harmonization. So you bring equivalence wherever the person goes, even if they are on follow-up, the tumor markers remain the same. There are some common things. For example, immunoassays are based on the principle of antigen-antibody interactions. The biomarker or the tumor marker serves as the antigen, and the detection is done by the antibody. Commonly employed immunoassay methods are enzyme-linked immunosome, built as ELISA, variants of ELISA method. ELISA is nowadays not used much in modern laboratories. So you will be finding at least things like Delphia, ENIT, nephelometry, turbidimetry, chemiluminescence, electrochemiluminescence, electrofluorescence, fluorescence. These are the most common. Colorimetric. Colorimetric, if you are using these tumor markers to detect things on slides. So tumor markers not only cover the branch of clinical chemistry, but they have also extended into parallel disciplines which diagnose tumor. For example, oncopathology, histopathology, and so on. The chemiluminescence assay, if I can show you, if this is the antigen, you have a monoclonal antibody. Usually, it's a monoclonal antibody which binds to the antigen. And there you have a secondary antibody which binds to the primary antibody, primary monoclonal antibody, and is stacked to an enzyme. The enzyme converts a substrate to a luminescent substrate, and that light is measured. It can be luminol, it can be acridinium, it can be several other things. Most common what happens is that here you have uh, all these reacting in presence of hydrogen peroxide. That means whether you are using luminol, acridinium esters, dioxine, you are oxidizing it. And that oxidation is resulting in the light which is being produced. And therefore, you are capturing the signal. When you look at the technologies, if you are adapting an instrument, how do you differentiate? Now, look at some of the theoretical things because these will be very difficult for us to prove in the laboratory whether this is actually happening. But luminol and substances similar to luminol were the initial things to have been developed. The light produced is in a very short interval, whereas acridinium and dioxine esters, they produce light and it remains, it lingers for a longer time. Longer time does not mean in minutes, but in microseconds, but good enough for the photomultiplier tubes to capture. So what is said is that if there is a persistence of signal for some time, it's a good capture. But do test it out as I will come in later slides that how do you do it. But this is the theory which comes up regularly. So this is the basic of a chemiluminescent immunoassay. And of course, the principle is sandwich. So I'm not going to classify immunoassays because that is beyond the scope of the seminar. Here, the thing is that they are all sandwich immunoassays already I have told, and they are competitive immunoassays. So one has to go and read up what is competitive and non-competitive. Competitive sandwich immunoassays, and all of them require a washing step. This diagram is complicated, and I am not going to describe to you everything about electrochemiluminescence. What happens in electrochemiluminescence is that similar to this, you have a antigen, there is a monoclonal antibody, and there is another monoclonal antibody or a polyclonal antibody tagged to streptavidin. Now that streptavidin is captured by nanoparticles which are coated with biotin. The secondary antibody binds to nanoparticles which are coated with biotin, but these nanoparticles are magnetically attracted, are capable, maybe iron filings as well, iron nanoparticles, which are capable of being attracted to an electrode. So when they settle down on the electrode, they generate a voltage. Now, depending on the concentration, this voltage is captured, and that is how the electrochemiluminescence assay takes place. A curve is developed, and depending on the curve, the concentration is given. Nowadays, you must have seen that some companies, they give you 6-point calibrators, some give you 2-point calibrators, some don't give you calibrators at all. They give you master calibrator barcodes. So, if you are validating or verifying or the machine is coming for the first time, you can ask the company whether they have got the calibrators, the actual calibrators with them for you to test them out as a sample and see their uncertainty and tolerance values. Similar would be the case for immunofluorescence assay, but now auramine, rhodamine, the substrate would be a fluorochrome and the detection will be a by a fluorimeter. There is nothing special about all these things. It's all excitation of electrons from one level, and when they come down, they emit light, they emit fluorescence, or they emit something they fix onto the electrode in such a way that a voltage is generated. Enzyme immunoassays, I have already talked to you. There may be a research program which calls for a prostatic acid phosphatase. It's cumbersome to do, but you may be asked to do it. That's how. But LDH, G6PD-H, alkaline phosphatase. So all these things, they become tumor markers in certain context. Even GGT, the ratio of GGT alpha globulin, but those are not enzymes, they are ordinary metabolites. So things become important as tumor markers as and when required, including neuron-specific enolase. Neuron-specific enolase is an emerging tumor marker. This is very interesting when you talk about HPLC and MSMS, the hyphenated technique. You can use it to do catecholamines and metabolites and also amyloids. So what you do, you have the tumor, you do a micro dissection. So you have a special platform to do a micro punch out areas in the blocks. You homogenize it or sonicate it, then digest the proteins, take the protein spectra, convert it into a bioinformatic thing, and then you match it with the protein library. For example, in amyloidosis, you can do this. The technique is coming up, but has not been popularized because of the extensive use of manual methods and the time it takes. But there is no other way to detect amyloidosis or response to amyloidosis other than these things. Because it can be done directly from a bone marrow. So you need not go and do a kidney biopsy and wait till the kidney is damaged. That's one of the uses. I won't go into histochemistry, FISH and PCR, but just be aware that these technologies are available and also liquid biopsy. You also have microfluidics and microarrays which are going to come. Now, there are certain disadvantages of tumor markers. Lack of specificity, because even the healthy tissues may produce them, so it can confuse. Lack of sensitivity. So they may not produce. That's it. Some tumors, for example, let's say beta-2 microglobulin is not produced in 30% of the multiple myeloma cases. You do not even have a paraprotein spike in 15% of the paraprotein cases. Biological variability in the patient or between patients, analytical variability. So it's a common practice in our country that people, if they are not satisfied or if the clinician is not satisfied, they will roam about with a tumor marker diagnosis from one lab to the other. And once somebody is satisfied mentally, they will say this report is correct, the other reports are wrong. But this is not how things should proceed. If the laboratory which has done a tumor marker is in question, the laboratory itself should be questioned on the tumor marker. And there are many ways to solve this analytical variability by the laboratory itself. They may use a different method. They may use some antibodies, monoclonal antibodies, and so on. Limited diagnostic utility because of the lack of specificity and sensitivity. Sometimes in analytical variability, what can happen is a person may develop antibodies to the tumor marker detection system itself. For example, monoclonal antibodies, human anti-mouse monoclonal antibodies, they will interfere in the diagnosis of the tumor itself. Critical interferences can be high dose hook effect. So if you have very high concentration of the antigen, you will get a very low value. People will question that the tumor burden is so high, how come it's so low? Then you have to dilute. There are procedures. That means these high antigen, they hook the analytical system and take it away from what it is intended to do. So there is high dose hook effect specimen carryover from heterophilic human anti-mouse antibodies, pharmaceutical interferences. For example, if somebody is taking biotin or somebody is taking something, for example, which increases the tumor marker, TSH is a tumor marker for thyroid cancers. If T4, T3 is being T4, sorry, not T3, T4 is being taken by the patient in the form of thyroxine as a drug, you know what can happen. The FT4 measurements will all be going hither. It is always a team-based approach. So you have to talk to the biochemist for special cases in selection of tumor markers. For example, inhibin A, inhibin B, HE4, MAC, S100, and approach. What is the approach if you are using multiple tumor markers? So you have to rope in a laboratorian to discuss all these issues. Value-added services from the laboratory may include trends and spikes and the uncertainty values, the reference change values of a tumor marker. Ethical considerations. It's not only ethical considerations for the patients in choice of a tumor marker, but also ethical considerations when you say that this laboratory has given me a wrong result, so please go to the other laboratory. So when you are actually in that frame of mind, when you are not liking the result, please speak to the laboratory. And ISO 15189-2022 now stresses on risk management of the patient. So you must have or draft at least an analytical draft that if there is a failure of tumor marker analysis, the clinician or the patient is not satisfied, how would you manage the risk? Quality assurance. In blue, these are almost mandatory. Imprecision, bias, AMR, method comparison, carryover. LOD, LOQ, BRI are optional. You can do them or not do them or do away with them as and when required. So that is in nutshell what I had to describe to you as the modern approach to tumor marker analysis. So mainly the takeaway are the new technologies, the evaluation of the new technologies, the ideal tumor markers and how your tumor marker in a particular context differs, the analytical sensitivity specificity, the clinical sensitivity specificity, and so on. And of course, the team-based approach that we must take when we are interpreting a tumor marker. The interpretation should happen at the level of the laboratory as well as at the level of the clinicians. So having said all these things, thank you for patient listening. I hand over the microphone to Mr. Mahajan now.
Thank you very much, Dr. Chakraborty. That was very enlightening. This is a very vast subject, and even getting how do you call it, an established overview over a period of 35-40 minutes is quite challenging. So thank you very much for your efforts, sir, in putting this thing together and sharing your knowledge with us. I do have a couple of questions, and I would request your interest in those questions. So in your experience, what are the key bottlenecks in since we're talking about lab automation? So in your experience, what are the key bottlenecks in implementing full lab automation in the Indian clinical setting, particularly in oncology diagnostics, sir? We don't find too many specialized oncology settings out here.
Yeah, so when we talk about full automation, first of all, one bottleneck can be the load factor, how much you have. It is going to be different between a hospital-based lab and a standalone lab. Then how many sections are connected to your track and your middleware systems? Interfacing legacy systems, legacy LIS systems with your middleware system may be another bottleneck. And the other main bottleneck is the human adaptability to the need for automation in laboratories. So four, I would restrict to four, but there are many, and most of them are human factors. rather than, of course, you can have a small space, design restrictions, and so on. All those can be discussed, but they are others. They are under miscellaneous.
All right. Thank you, sir. And, there's another thought that came to my mind because I was looking if somebody else had written some questions. I think a lot of our audience would have been in awe of what they heard today. But how do automated platforms compare in terms of sensitivity and specificity when detecting low expression cancer biomarkers? Are there trade offs between speed and accuracy that we are looking at nowadays?
Well, the speed and accuracy, the speed has improved. I would say the modern platforms and robotics has increased the speed. The lowest speed or the maximum speed can be 20 minutes. It's very rare to see something going up to an hour nowadays. But accuracy wise, you have to have, that's why I told you the discussion with the team,
Yeah.
the clinical team, whether they're appreciative of what values they are getting. An example in case is the PIFCA molecule. The PIFCA2 molecule is, if combined with AFP-CA99, is giving good response in case of hepatocellular cancers. That's one of the examples of a good use of a tumor marker. So if clinicians are satisfied, you go ahead with it. It's a
Thank you.
trade-off between speed and accuracy. I
There's
would say
always
trade-off, but accuracy may be called into question. So only looking at the analytical accuracy is not enough, is what I intend to say.
fair point, sir. Thank you very much, doctor. And we will have a formal certificate sent to Kolkata. But in the meantime,
Thank you.
this is one of the leftovers we have from our carryover from the COVID era, where we do present a certificate of appreciation electronically. Mr. Dinabandhu Nandi will be in touch with you for the actual certificate, but please accept this small certificate as a token of our appreciation, sir. Thank you very much for
Thank you
it.
very much. Thank you very much. It's much appreciated. It's much appreciated.
Thank you, sir. And thank you all for
Thank
attending
you.
today. And we look forward to seeing you on our next webinar sometime in the month of June. Have a good day and Jai Hind. Thank you.
Okay. Have a good day, everybody. So.